right?
Okay, so I'm going to allow Dr. Dania Badetsky, who I've introduced, to start off our morning.
Hi, good morning, everyone. This is the next event in our training program. So let me introduce our speakers today. Rami Burstein is the John Hadley White Professor of Anesthesia and Neuroscience at Harvard Medical School and the Vice Chairman of Research in the Department of Anesthesia and Critical Care at Beth Israel Diaconus Medical Center. In the past 10 years, he founded the Translational Headache Research Center. It's a multidisciplinary team with neuroanatomists, electrophysiologists, molecular biologists, geneticists, bioinformatics, neurologists, neurosurgeons, internists, and anesthesiologists. His overall aim is to understand the complex sensory, affective, autonomic, and cognitive experiences described by patients before, during, and after the headache attacks. In the preclinical studies, he attempts to reveal the neural basis of migraine-associated symptoms and the physiological and molecular events that mediate the development of neuronal plasticity. In the clinical studies, he attempts to document novel aspects of migraine-associated neurological symptoms as it guides preclinical studies. His research is mostly founded by the National Institute of Neurological Disorders and Stroke, and to a lesser extent, he is also active in pharma clinical trials. In the past years, he has been serving as reviewer for the NIH, the Wellcome Trust, the Canadian Institute of Health Research Science, the Dana Foundation Program in Brain and Immunoimaging, Rita Allen Foundation, Rookdale Foundation, and the Ezen New Scholars Program in Aging. And he's going to speak about the science behind migraine. So please, Rami.
Great, thanks. You know, I can speak for 32 hours and tell you things that you didn't hear before, but I only have 45 minutes. So I had to pick up only one little topic, one topic within the world of headache that I can talk within 45 minutes, and I'm gonna try to make it interesting. And rather than tell you the obvious thing about migraine, take you through maybe one of the more interesting question that I think we don't know enough, and we're not tackling it enough, and that is it is first focusing on how is it that the brain decides that it's time to have a headache. How is it that patient can tell you that if they are exposed to perfume, or they didn't sleep enough, or they skip a meal, or they got stressed, why is it that 9 out of 10 they don't get a headache, and in 1 out of 10 times they do get a headache? What is it that makes the brain agree to get a headache? That's number one. Number two is, if you look at the list here, in the past, we thought about migraine in a very simplistic way. We thought that there are pain signals that come from the meninges, through the tentorial nerve, through the trigeminal ganglion to the spinal cord, and from the spinal cord it goes to the thalamus, and from the thalamus it goes to the cortex. But as time goes by, and we get better with our techniques and our knowledge, we realize that this is way too simplistic and it limits our thinking. So if you just put the ballpark of how you think about a disease, you really have to start with the anatomy. The anatomical connection really define neurology for neurologists, how they think about symptoms and diseases and pathophysiology of different conditions. So if you take the peripheral nervous system, in the past we thought the signal come from the door. Now we know that the same axons can also get branches that cross the arachnoid space and get to the pia. And we also know that there are axons that cross the sutures of the calvaria and go to the periosteum and to muscles. Now, not only that, but this peripheral part not only sends signal from multiple sources inside and outside the calvaria, the bones, but it also contains different classes of pain fibers that respond differently to different stimuli, like the unmyelinated and the myelinated, completely different. They play completely different role. As they get into the spinal trigeminal nucleus in the upper cervical spinal cord, the nucleus caudalis, they don't just go to the thalamus, they go to multiple brainstem area and the hypothalamus and the amygdala and nucleus accumbens and the septal nuclei, all limbic area that really can define to you how migraine is associated with irritability, anger, anxiety, fear, low energy and tiredness, depression, yawning, frequent urination, teary eyes, loss of appetite, nausea, sleep disturbances, a whole host of symptoms that migraine patients often describe to us before and during the migraine. Now, if you take the next station from the thalamus to the cortex, basically, so we know about photophobia and phonophobia and osmophobia, but migraine patients talk about clumsiness and spatial and changes in spatial orientation and transient amnesia, difficulty to remember things like phone numbers and names that should not happen to people in their 20s and 30s. And it goes away when the migraine goes away. A whole host of things that really, that can really put together to us when we follow the axon that go from the thalamus to the motor cortex, insula, the primary and secondary somatosensory cortex, the parietal association cortex, the retrosplenius cortex, the auditory cortex, the visual cortex, the olfactory cortex. All of these are connections that now we follow neuron by neuron by neuron to put together a concept to everything that we see in migraine patients. So because we know the information that have been told all along was about the information that happened in the spinal cord and to a lesser degree anywhere else, I'm gonna start by the hypothalamus because I think that it explains large number of symptoms that we never thought about. And when you think about the hypothalamus can, we think about it in two contexts. One context is, can the hypothalamus in response to pain give rise to all these symptoms? Number one. Number two, can the hypothalamus really trigger a migraine? Okay, so let me start with the first question. So maybe before I get to the hypothalamus, just to summarize for you in a simplest way. So pain signal that go from the meninges goes to the trigeminal ganglia to the spinal trigeminal nucleus. When these neurons get sensitized and begin to respond to non-painful, to changes, intracranial changes, to changes in intracranial pressure that usually they don't respond to, right intracranial pressure go 410 millimeter mercury with the pulsation of the heart. So in the absence of migraine, the receptors here do not detect it. During migraine, when they get sensitized, they begin to detect it. We can see it in functional MRI during migraine. And it is really this peripheral sensitization that can explain to us why migraine headache throbs and why bending over, sneezing, coughing, things that increase intracranial pressure from maybe 4 to 24 momentarily will make the headache more painful. Today, we can image it in a trigeminal ganglion in the first division of the trigeminal ganglion. Exactly the same way, when pain signals travel from the meninges, from the dura, through the ganglion to the spinal trigeminal nucleus, and they sensitize these neurons, and these neurons now begin to respond to stimulation that they would not respond under in the absence of migraine. These neurons now begin to respond to non-painful stimulation like brushing the skin or stretching your neck. And this response comes from the periorbital area because these neurons receive input from the ophthalmic branch of the trigeminal nerve, but not from the maxillary or mandibular. And they also receive signal from dorsal root ganglion of C2, 3, 4, 5, which send mostly sensory signal from muscles in the back of for muscles of the neck. So when this neuron here gets sensitized, the secondary neuron in the spinal trigeminal nucleus, we can image it in human, we can record from them in animals when they turn from green to red. And it is really this event that cause them to, the glutamate that is released here and cause it to get sensitized, can explain cutaneous allodynia of the skin when they can't touch their skin, they can't put baseball head, whatever it's called. It used to call them painful hair syndrome in the 1800s, and it can explain muscle tenderness that develop after the onset of migraine. When we move to the thalamus, we see exactly the same thing, that neuron in the thalamus during migraine turn from blue to red, they get sensitized. We can record from it and see this neuron turn from green to red. We can image them. And basically it is this sensitization thalamus that can explain to us, those patients tell us that the skin become hypersensitive all over the body. All right, so this is the classical part that explains some of the headache characteristics of migraine: the throbbing, the skin hypersensitivity, the muscle tenderness, the I don't touch me, leave me alone, I don't massage me, I don't want tight clothes, I don't want anything tight, nothing feels good on my skin. All right, I'm shifting now to my concept of the hypothalamus. Okay, so, oops, here we go. So the integration of sensory, physiological, and cognitive signal by hypothalamic neurons that regulate hormonal secretion and activity of brainstem and spinal cord neurons that mediate autonomic response could provide a partial answer to the question of how sensory signal produce endocrine, autonomic, and affective responses, right? It's the basics of neurological functions. Okay, so if we look at what the hypothalamus is during migraine, we start here. All the neurons in C2, C1, nucleus caudalis, and nucleus interpolaris that are marked here in black are neurons that are usually activated during pain that come from the head and the face, and they send these signals to the hypothalamus. When we saw it at the beginning, we were surprised to see that there are nearly 10,000 neurons. It's almost as large as the spinothalamic tract that project to the hypothalamus. Okay. Where do they go? So when they project to the hypothalamus, because the hypothalamus is not a magic one thing, they go to the preoptic area, to the periphonical area, to the posterior hypothalamus, to the lateral nucleus, to the dorsomedial, to the suprachiasmatic nucleus, to the supraoptic nuclei. Each one of these nuclei within the hypothalamus play a completely different role in food intake, in appetite, in sleep, in body temperature regulation, in a whole host of things. When you look at it, there is something really interesting that is coming about the prioritization of the face in general. So you can do this experiment in human. So we record from these neurons and we cause pain all over the body. And look at that. Tail, small response. The pause, the hind front pause, small response. And look what happened as you get to the face and to the mouth. The responses get much bigger because the hypothalamus needs to pay more attention to pain signals that come from the face because they give it so much more information about survival. And it's the same in the meninges. The hypothalamus get large input from the intracranial dura. And the importance of this is the following. If you put it all together, these are the functional consideration in the context of migraine. So there are neurons in the spinal cord that send painful signals to multiple hypothalamic nuclei that contain neurons that play a critical role in regulation of body temperature, food, and water intake, sleep, and circadian rhythm. And it is really through this connection that painful signal give rise to loss of appetite in migraine, the perception of thirst, I need to drink, it makes me feel better, disruption of sleep, stress, anger and aggression, frequent urination, feeling cold and shivery or hot and sweaty, frequent yawning, teary eyes, stuffy nose, being lethargic, etc. All symptoms that by the time you see your migraine patient number 10,000 in a clinic, you hear the symptoms again and again and again. They come, patient describe it as symptoms associated with migraine. So the hypothalamus receives signals about pain that can really change how we feel way outside the experience of pain. Okay, now this is one role of the hypothalamus. Another one is the following. For many years, we know that migraine patients have what we call prodromes. They might, not consistently, but the majority of migraine patients, if you ask them the following question, do you know you're about to get a migraine? Many of them will say yes. Do you know you're about to get a migraine a day before, a few hours before, an hour before, a few minutes before? In many cases, the answer is yes, even though it's not consistent. So what they talk about, frequent yawning, sometimes frequent urination, sometimes stuffy or running nose, sometimes teary eyes, sometimes their mood change, they get either euphoric or depressed or angry or upset. Sometimes their speech would change before the headache starts. Sometimes they just get more sensitive to light and noise before the headache starts. Sometimes they just crave for food before the headache starts. When you put all of it together, you realize that many of what they tell us begin in the hypothalamus. So it is this, what we call prodromes, that we can connect the hypothalamus, gave rise to a novel thinking that the hypothalamus can trigger a migraine. Of course, the concept is extremely complicated because even if hypothalamic neurons begin to misbehave and do things that are not right, and there are prodromes, and there are neurological symptoms that patient can describe, and at the end of it there is a migraine, you can still not explain how a neuron in the hypothalamus that regulates sleep or appetite end up giving you a headache around one eye. The gap between how is it that I begin to crave for food, or I start yawning, and 2 hours later it hurts only around one eye, is a huge gap in our knowledge. Of course, I don't think that it's going directly from the hypothalamus to activation of a single neuron that only get receptive field around the eye. It's way more complicated than that. And I'm gonna try to tackle it in the next part. So I'm gonna give you the message so you can follow as I go along. So we assume that pain signals, that sensory signal from the meninges, from the dura, goes through the trigeminal vascular system, so the ganglion, the spinal cord, to the thalamus, and there they stop. The thalamus plays a huge role in, the thalamus is really the conductor of the cortex. It tells the cortex, the thalamus that makes the decision on what the cortex should know and what the cortex should not know. So there are things that the cortex must know, and the thalamus let it know. And the moment the cortex knows it, it doesn't want to hear it again, because it needs to keep room to pay attention to other things that may be more important for survival. So the cortex has a way to tell the thalamus, okay, you told me that, don't tell me again, I'm gonna turn you off. The thalamocortical and cortical thalamic information, how they talk to each other, is not determined by the cortex. It's really determined by the hypothalamus. So here is how it works. So if thalamic neurons play a central role in the selection, amplification, and prioritization process that determine which type of information should be made available to the cortex at any given time.
10-kor jön az első páciens, és 12-kor van elvileg az utolsó páciens.
Okay, so let me start with the data and then take you into that. Okay, so what you're going to see in the next few slides is the following. In red are neurons that are activated during migraine. They are in the thalamus and they project to the cortex. So we look at these neurons and we see the massive input that they receive from glutamate. Right? Glutamate is excitatory, it tells them to talk, it comes from many places. They receive massive input from glutamate. Role in migraine, development of neuronal hyperexcitability, sensitization, altered connectivity, and headache duration. They get large input, as you know, from the reticular thalamic nucleus, which is all GABAergic and all inhibitory. And it is an important part for the following reason. If the thalamic neurons send information about headache to the cortex, this information also goes to the reticular thalamic nucleus. And at that point, once the information left, the cortex doesn't want to hear it again. It is the role of these neurons to go back and tell them, okay, you said it once, you don't have to say it again. It's time to be quiet. Neurons in the thalamus receive large input from dopamine. And if you look at, I lost everybody, I guess. And if you look at dopamine role in migraine, so thalamic dopamine can be involved in drug and addiction, impulse control, affect and attention, decision-making, and in the context of migraine, contribute to behaviors that lead to medication overuse headache, exacerbation of headache by negative emotions like stress, effort to control anger, all these things. Thalamocortical neurons receive input from histamine. Activation of H1 receptor and hence slow depolarization current basically switch the discharge of thalamic neurons from drowsiness to wakefulness. They receive input from noradrenaline. They receive input from serotonin. They receive input from melanin concentrating hormone. They receive input from orexin. And if you put it together, here's what I'm trying to tell you. So migraine, headache, pain signal come from the meninges, so the spinal trigeminal nucleus to the thalamus. Usually, they will activate the neurons in the thalamus that goes to the cortex and tell the cortex there's a headache. Now, these neurons in the thalamus, their activity is regulated. Everything that I showed you is summarized here. It is regulated by hypothalamic neurons a little bit of brainstem neurons that contain histamine that is affected by being awake or being asleep. Dopamine that is affected by negative emotion, irritability, being stressed, cognitive effort that we make. That it is regulated by orexin that plays a role in food withdrawal and in sleep-wake cycle and how hungry we are. It is affected by glutamate. It is affected by noradrenaline that plays a role in depression, anxiety. So this is excitatory. Serotonin can be excitatory, can be inhibitory, depends on the level. It's affected by GABA, inhibitory. If you put it all together, you realize that here's the message I'm trying to send you. So this diverse input suggests that the genesis of migraine, that the beginning of migraine is determined by opposing peptidergic forces, and that the so-called decision of which chemical system will dominate the firing of thalamic trigeminal vascular neurons at any given time is determined by constantly changing physiological, like sleep-wake, food intake, behavioral, like addiction, social isolation, cognitive, like paying attention, learning, memory, making effort, and affective adjustment that needed to preserve emotional and physiological homeostasis. Basically, what I'm telling you is pain signals that are a part of the beginning of a migraine attack can flow from the periphery to the spinal cord to the thalamus all the time, or at event that occurs. But it does mean the thalamus will let the cortex see it. The thalamus would tell the thalamic neurons, would give the thalamic neurons the permission to talk to the cortex, or what makes it what plays a role in the decision or whether this information will stop here or go into the cortex are all these forces. So if you're stressed, you don't get a migraine. When the stress goes away, there is less dopamine, you can get a migraine, right? It's a Friday night migraine, it's a weekend migraine, it's going on a vacation migraine. It's the evening when you come home that you get a migraine at the end of a stressful day. It can explain why a patient said to you, well, I can't drink wine. I drink wine, or I can't eat chocolate, or I can't eat cheese because I get a headache. Well, it can be true 1 out of 10 times. So what determined that in a time that the patient get a glass of wine, they did get a migraine, or the time they were exposed to a perfume, they got a migraine? What determines it is what is the emotional and physiological homeostasis that is regulated by all these chemical pathways at a given time that the patient is exposed to a migraine trigger. If the sum of all this is excitability and the guard is down, the headache will begin. But if the sum of all of this is inhibition, the headache will not start. I'm going to take you into one example that I think you'll find interesting. So here is how it is. It is really coming to the migraine patient will tell you, if I don't sleep enough, I get a migraine. If I sleep too much, I get a migraine. If I skip a meal, I get a migraine. One of the more common triggers, some of the most common trigger of migraine. So how can skipping a meal facilitate a migraine? So look at that. Let's start on the left. When we skip a meal, orexin neurons are excited by the falling glucose level, and their activation promote food intake and wakefulness. When glucose level goes down, orexin neurons get activated. When they get activated, they fire, and through orexin and B receptors, they mediate depolarization, and thalamic neurons begin to fire. These are the thalamic neurons that are activated during migraine. They begin to fire, and the cortex can see that. Now, glucose level does one more thing. When it goes down, MCH neuron, the melanin concentrating hormone in the hypothalamus that project to the thalamus, get silent. When they get silent, there's no more inhibition. So we eat. An MCH neuron, we ate enough, glucose level went up, orexin neuron shut down because we ate enough, and now you can go to sleep. And MCH neurons kick in and begin to fire. When MCH neurons begin to fire, they release GABA in the thalamus and shut down the thalamus, the ability of thalamocortical neurons to send signals to the cortex. So if you take only skipping a meal, you realize that skipping a meal will activate orexin neurons, that will give thalamic neurons the ability to fire, they depolarize them. As soon as we eat and glucose goes down, firing stops and it begins in neurons that release GABA in the thalamus. So now, if you go back to evolution, you realize that animals only were awake only for one reason, to eat enough. And as soon as they ate enough, they had no reason to be awake and they went to sleep, which of course will explain to many people why is it that after every meal they are so sleepy. It is how evolution made us, that we are awake to eat, but we found a way to eat enough so we don't need to be awake to eat the entire time we are awake. We can be awake without eating, but it wasn't true in animals in the past. So basically, look at what happened when we are awake. When you're awake, what is active is what is releasing the thalamus is noradrenaline, acetylcholine, serotonin, dopamine, orexin, and histamine from different parts of the brainstem and the hypothalamus. This is all sensitizing and activating the thalamus. When we are asleep, all these neurons are quiet, and the two neurons that are active are neurons that release galanin from the ventral lateral preoptic area and neurons that release MCH from the hypothalamus. These neurons are all inhibitory, and they shut down the thalamus. It's a big part of how we fall asleep. It is this signal that allows you to, that not only allows you to sleep, but it is this signal that can explain to you why sleep is one of the most effective way to treat migraine. Think about it. If you ask migraine patient, if you look at the literature, you see that migraine can last 4 to 72 hours. But by far the most common occurrence is that migraine lasts for 24 hours. And what it is it starts on a Monday and it lasts all day, and patients go to sleep and they wake up and they don't have a headache. This is the most common story. So what is it in sleep that allows you to wake up without a headache? It is really the fact that you get several hours where the thalamus does not see acetylcholine, noradrenaline, serotonin, dopamine, orexin, and histamine, and what it sees is galanin and MCH. It gets quiet. So what I'm saying is that all this can happen in the presence of pain signals that come from the periphery. So there is a reason why you have a migraine, and the pain signal continuously coming from the periphery, so the spinal cord, to the thalamus. But we get a break when thalamic neurons shut down, and the migraine will come back when we wake up, and which again is a common thing on migraine attack that lasts for several days. You wake up and you get the migraine like half an hour after you wake up, and the patient thinks that it's a new migraine attack, but it isn't. It's really the same migraine attack that stopped when we were asleep. All right, so here is the conceptual summary of that. It really says that this diverse input suggests No, I talked about it. Let's move on. Basically, what I'm trying to tell you is that yes, the hypothalamus. Let me take one more. The hypothalamus can. We can call it. Can the hypothalamus trigger a migraine? I don't think it can trigger a migraine in the context of causing a pain signal in the periphery to fire. But it can allow the cortex to know that there is a migraine by opening the gate and allowing painful signals to leave the thalamus and go to the cortex. And when the hypothalamus is in a different state and you turn it off, the information from the thalamus to the cortex stops or is being reduced. Okay. I have 10 more minutes. I'm gonna take you into maybe one more thing, and that is just the concept of how migraine can make patients lose their appetite, which happen in 82% of the patients who reported they lose appetite even when they were not nauseous. So we go to animals, we show that if we activate their pain pathway that is activated during migraine, they stop eating. And basically, here is the pathway. It activates the pain signals in the, let me take you straight to the summary of that. I think it'd be more interesting. So basically, here is a summary of all this part. I left out the anatomy. Here, the physiology. Pain signals come to the spinal trigeminal nucleus. From there, they go to the parabrachial nucleus, where they activate CCK neurons. CCK neurons project to the ventromedial hypothalamus and work on neurons that have CCK receptor type B, and when they activate neurons that have the CCK receptor type B, they lose their appetite. This pathway of CCK or targeting the CCK receptor B with a GAN antagonist has been a subject of many drug companies that try to develop medication for obesity, for people to start to lose their appetite. They were targeting the CCK receptor B in the hypothalamus. Basically, what I skipped is showing you how during migraine there is activation of a pathway that can explain to you, again, going into the hypothalamus, one more symptom, loss of appetite. Okay, so I'm gonna take you from there into the last part, and that is the following. So, how the hypothalamus regulate physiological, hormonal, sympathetic, and parasympathetic responses in migraine. So it really starts with an interesting clinical study where we brought migraine patients, asked them, put them in front of different lights during migraine, and ask them to tell us everything that they feel not related to the headache. Of course, light make the headache more painful, but look at that. So here's the words that they used. It make me anxious, angry, irritable, whatever, nervous, hopeless, needy, sad. They talked about feeling dizzy, lightheadedness, nausea, vomiting, stomach ache, rhinorrhea, lacrimation, a whole host of things that really suggest that the hypothalamus regulate in migraine patients. So we look at it and we see that all these autonomic or affective or hypothalamic things really happen during migraine, happen way less in the absence of migraine, and don't really happen in people, and happen way less in people who don't have migraine. So if you follow just basic anatomy of how during migraine there is exaggerated activation of hypothalamic neurons that contain dopamine and histamine and MCH and orexin and vasopressin and oxytocin. Here is what you get. What you get is you have a migraine and you're exposed to light, which under normal condition will not do a single thing. But during migraine, it activates neurons in the hypothalamus that contain dopamine, MCH, orexin, histamine, oxytocin, vasopressin. And if you put it together, you realize dopamine really plays a major role in yawning. It plays a role in all negative effects, right? In being angry and irritable and depressed and anxious and hopeless and stressed and sad. You look at MCH and orexin and histamine. It plays a role in sleepy and drowsiness and hunger and hot flashes and warm face and vasopressin and thirst. You can really begin to explain a whole host of things that you hear from patients. How does it happen? So a big part of it is really coming here. So you of course, the hypothalamus, for the hypothalamus to do it, it has to connect to the autonomic nervous system. So you do some fancy anatomy and you look at the neurons that are activated during migraine, and you see that they project to the sympathetic preganglionic neurons in the spinal cord, to the IML. You can see all this connection. I'm just summarizing to you. I'm summarizing to you the connection. And basically, if you look at it, you realize that it is this connection that can explain to your patient that get stressed and get anxious and tell you that they feel shortness of breath, fast breathing, increased heart rate, dry mouth, chest tightness, throat tightness. And if you go to the parasympathetic nervous system, you see the same connections are there. The neurons that I just showed you before connect directly to the superior salivary nucleus, to the preganglionic parasympathetic neuron that can really put for us together anatomical ballpark for lightheadedness, dizziness, nausea, vomiting, anorexia, lacrimation that migraine patients talk about. All right. So if I put it together, I think that the message that I'm trying to send to you about the hypothalamus is that it's really it's the ventral horn of emotion. It's the emotional motor system. It really translates emotion into action, into something that happened. And it happened because whatever happened in the hypothalamus eventually go to the sympathetic and parasympathetic nervous system and sensory and allow it to regulate sympathetic and parasympathetic tone. And that all this begin with sensory input, sensory affective input, physiological input it receives for multiple connections. So I'm going to stop here. I flooded you with huge amount of information that is heavy on science, but has a lot of but can put for us a neuronal framework at which we think about how migraine give rise to symptoms that are really specific to migraine, and how the brain can determine whether we will or will not feel a headache, even though the pain signals come from the periphery. Or in other words, how do we determine whether we are going to get the next migraine attack? I'm going to stop here, open it for discussion, let you ask any question if you have. And if the lecture was a little bit too scientific, I apologize.
Not at all, Rami. Thank you very much. My question is, a lot of what you're talking about is what's very popular now is the prodromal phase of a migraine and how to treat a migraine before the pain actually develops. Well, how do you foresee what medications that we have in our armamentarium presently may be efficacious in the treatment of the prodromal phase of a migraine?
So, right, I think that because the hypothalamus plays a role in so many different functions, usually it's a risky thing to try to mess up with the hypothalamus. Because, I mean, it's a problem that migraine patients said, the drugs that act centrally have so many side effects that after 3 months they throw them away and they don't want to use them because the risk outweighs the benefit. I think that, so take for example, serotonin. So the serotonin, you know, some doctors give SSRI to migraine patients, and there are some, there is no evidence-based medicine on that, but there are many patients that benefit from some intervention with SSRI. So you think about it, serotonin at a low level in the thalamus shuts down, is inhibitory. And as soon as you increase serotonin on the same neuron, it becomes when the concentration, the level of serotonin in the thalamus is high, now it becomes inhibitory. So does it make sense to give SSRI? It does, because it turns itself from excitatory to inhibitory when we increase the level of serotonin in the thalamus. But there's a price to pay to that, and which haunt us with the dopaminergic and the noradrenergic and with all these drugs. So unfortunately, I think that the question that is coming is, why is it that the hypothalamus is so different in migraine patients? Why is it that for people who don't have migraine, you can skip a night of sleep and you can sleep a night of eating and you can get stressed and you don't get a headache? And what is it that makes migraine patients so different? Why is it that they are so conservative? They have to sleep their 6 or 7 hours a night. They have to go to sleep at the same time and wake up at the same time. They have to eat their 4 small meals a day. They can't get too stressed. They can't get too cold. They can't get too hot. What is it that made the neuron in the hypothalamus of migraine patient so sensitive that any deviation from homeostasis will give them a migraine? So there are 2 answers to that. There are 2 options. Either they were born like this and it is genetic and you can't really change it, or it is not, or it is a result of 10 and 15 and 20 years of having the hypothalamus bombarded by millions and millions of pain signals that come from the meninges that happen during migraine. And it is eventually, after years of being exposed to non-stop pain signals that repeatedly come during migraine attack, that these pain signals eventually changed the physiological, the molecular, cellular, biochemical, and physiological properties of neurons in the hypothalamus, and they become so hypersensitive. And so I personally believe that this is the case. And I think that if we give migraine patients, I don't think that most migraine patients feel this, have described it to us in the first 2 or 3 years of their history with migraine. It happens when the years after their migraine begin, that they notice it. And I think that if we give migraine patient, or I hope that if we give migraine patient a break from migraine with drugs that block the pain signal in the periphery, like the CGRP monoclonal antibodies, and they go through 1 or 2 years without a headache, maybe 6 months without a headache, that the neurons in the hypothalamus will return to baseline and begin to function normally. And now they'll find out that skipping a meal doesn't give them a headache, and that not sleeping enough doesn't give them a headache. So, but this is speculation. We don't have the answer. We didn't do the studies. The question of whether it is a genetically predetermined or whether it is a result of experience of life is one question that we critically need to answer. And the other question is how abnormal activity in the hypothalamus end up in a headache around the eye. Because if you understand hypothalamic regulation, the hypothalamus, everything the hypothalamus does is bilateral. The projection from the hypothalamus to neurons in the spinal cord, in the brainstem, is all bilateral. There is nothing that is specific. If you have pain and the hypothalamus helps you get rid of it, it doesn't get rid of pain in one spot, it gets rid of pain everywhere.
Thank you very much for your answer. And I think there are several questions in the chat box, and also Nora Linkoff would like to ask a question, if I'm right. Nora?
Okay. So hi, thank you very much for that wonderful talk. I'm at University of Buffalo with Laszlo. So I have a tremendous number of patients who really, by now I believe them, swear that treatments such as date piercing, so piercing a part of their ear, or acupuncture, or cephaly treatments with that, that it really does decrease it. Are they hitting that first sensitization pathway from their scalp down towards their trigeminal nucleus? Is that where we assume there's disruption enough to improve and lessen the frequency, and that they need CGRP when they just cannot get desensitized enough, long enough?
Okay, so because we live in a world that is called evidence-based medicine, the way we answer this question is, if you talk to 1 million migraine patients, you'll hear 1 million different stories about things that help them get rid of the migraine. And like drinking mangosteen juice. Well, I don't know what mangosteen juice is, but there are patients who swear to you that they drink mangosteen juice and their migraine goes away. So I can tailor a story and physiological story that will explain to you why doing this can stop their migraine. The problem is that if we took 1,000 patients and we pierce their ears, we will probably get 20 where the headache goes away. And if we use a placebo to do it, we will not get any difference. So it's very difficult to tailor stories to things that we don't really know whether they work. Can it work? Sure, it can be like the gate control theory. You pay attention to something else, or you activate a pathway that plays an inhibitory interaction in the dorsal horn by activation of GABAergic neurons. But all of it is kind of a waste of time before you know whether it works or not. And what we believe in plays a huge role in how we feel. And because it's a question. A patient come to you and said, would you recommend for me to do acupuncture? So acupuncture is $400 and it costs a lot of money, and they have to do it time and time and time again. And all you can tell them is, if there is no risk in it, you can try it. If it doesn't work, don't do it. If it works, so I cannot recommend it because it failed every randomized controlled trial. Every trial that used placebo did not show any benefit of acupuncture over placebo in the treatment of acute or chronic migraine. It's not prophylactic. It doesn't reduce the number of migraine days per month. It doesn't stop a migraine. So some persons come and say, yeah, I like it, I do it, it helps me. And you say, how does it help you? Does it make your headache less painful? Does it make your headache last less? Does it eliminate some of the symptoms? Do you get less migraine? The answer to all of it is no. And they tell you that it helps them. So there's something so we can't catch it on clinical studies because it's not on the primary and secondary outcomes that any health organization accepts. So we can't tell them, go ahead and do acupuncture and pay the $400. I can't recommend it to them, but I can say to them, if you want to do it, try it. You're N of one. If it works, it's yes or no. If it works, it works. If it doesn't, it doesn't. But I can't recommend it, and I have a hard time even though I know a lot about the science of alternative medicine and acupuncture and the opioid system, and there is a lot of science about it, but it doesn't mount into treatment effect in migraine.
Thank you very much for...
That's what I tell my patients as well.
Thank you for...
That's what I also tell my patients.
Mm-hmm.
Thanks for your response and also for the question. And in the chat, there's a question by Agnes Virga from Boston that, what do you think about migraine attacks that wake the patient up from sleep? These are the worst and most difficult to treat. And I can confirm this because when I had my first migraine attack at the age of 40, it woke me up from sleeping and I suspected I had a subarachnoid hemorrhage at that time.
Yeah, so given that sleep is good for you, and given that sleep shuts down neurons in the hypothalamus, or that sleep really gives your brain the break that you need, a completely different lecture column about the lymphatic system. The question of it is easy to explain migraine that begins in the morning, 30 to 30 minutes, at 6 in the morning, 7 in the morning when we wake up. It is almost impossible to explain migraine that begins at 3 in the morning. And of course, the question of, is it because of migraine that you woke up, or is it because you woke up, you got a migraine? We don't have an answer to this question. Think about it. It's so simple, but we don't have an answer to that. How migraine attack that begins while we sleep, for a long time, we thought that, so in the process of waking up, histaminergic neurons that are found in 2 places in the hypothalamus flush the cortex with histamine. It's a big part of the mechanism that wakes you up, and eventually that gives rise to a release of nitric oxide. You can put a story. But histamine is not supposed to be released at 3 in the morning. So the middle of the night migraine attacks is, I think we don't have any neurological concept on where to begin to understand those migraine attacks.
Thank you very much. I think there's time for one more question. Professor Koller asked that if someone has a migraine headache, the pain is all over the head and not only in 1 or 2 points. So the pain is spread all over larger areas of the head, not only 1 or 2 points. How can you explain that?
Right. So yeah, this is it is an excellent question. We actually studied it. What is it that makes the headache spread from one spot in the temple to a larger spot, or makes it spread from the front to the back? This we can explain. We can explain it by sensitization of first sensitization of neuron in the spinal trigeminal nucleus, and then sensitization of neurons in the thalamus. And that usually the spread takes several hours. What we cannot explain is when the migraine jump from side to side. So the outpatient might start on one side and it ends up on the entire head. We can explain that in the pulvinar and the posterior thalamic nucleus. So we have that understanding. What we don't have is the migraine patient who tell us, I always have migraine on one side. So it's either left side or right side, left side or right side. But in the same attack, it can jump from one side to another and never be on both sides at the same time. It's like there is a switch of on and off in both sides of the dorsal horn that allow only one side to be active. We understand the spread within one side. We don't understand we understand the spread from one side to both sides. We don't understand the jump from one side to another.